Good afternoon, everyone. As the commentator said, I'm a member of the Okanagan Nation, and for any elders here today, so that you may know me, my grandparents are the late Ned Lewis and Irene Armstrong. I'm also a registered nurse, and I also used to work with Interior Health, so I'm very happy to see a lot of faces, a lot of familiar faces. I recently jumped ship from IHA. I'm now with the PHSA and First Nations Inuit Health, and I work for the Center of Disease Control now, particularly around TB control. And so there's a lot of new stuff about old TB that's coming full circle with infectious diseases now. So it's my hope later on, when I hopefully finish this master's, and maybe you can help me on a paper, but it's my hope that I will be able to contribute more to research that we can use in our communities, research by our own people that needs to be used at the community level. With that being said, in the area of cultural safety, I first heard about cultural safety back when I was a nursing student, and I had read Dr. Ramsden's thesis on cultural safety. It's a rather large document, and from there I started about a 2-year correspondence with Diana Wepa from New Zealand and the Nursing Council. And why I became interested in cultural safety, because as a nurse working in the hospital, local hospital here, there were times when I didn't feel safe as a First Nation healthcare professional. So if I wasn't feeling safe in this environment, then I wonder what my clients and patients and people who were seeking healthcare services, I often wonder how they felt. So I began to read more and dig more into research that had been going on out there. There was a lot of research at the time coming out of Australia, and research showing how Indigenous people were presenting more to emerge. They were presenting with issues of chronic disease management that should be handled in the community. Well, why weren't services working in communities? And where was the collaboration between health services and local community health services? There was such a divide. So we had people who kept reappearing into the hospital system with those illnesses, med errors, things that were totally avoidable. So I became more aware of the power structures kind of around healthcare services, and training as a nurse and coming into a hospital environment, seeing the hierarchy that there is, seeing how there's a hierarchy even within physicians and all kinds of healthcare providers. What was that power imbalance that I seen amongst healthcare providers and patients? Sure, we hold all this knowledge, and we'll decide how much we'll give you and what you should be doing with it. Things like that created a lot of demeaning experiences for First Nation people seeking health care. So it was in school that I first really started to see the assumptions that were happening around Aboriginal people and Aboriginal health. I remember as a student being in the nursing curriculum, and a student, actually, we were talking about social issues of the day, and we did get onto the topic of health status of Aboriginal people. And the student said, well, you know, I took a trip up to northern Alberta, and, you know, like all the houses have broken windows and they don't take care of anything. And hearing that was really disheartening, because this was a colleague who would be graduating with me with this misconception of my people. Because we don't all have broken windows and broken houses, but nobody ever told him any different. And so a lot of the students in the nursing curriculum at the time really hadn't been aware of Aboriginal health status or the impact of colonization on health outcomes and the big picture of health. And those were things that I was hoping would get addressed within my curriculum, but it was very, very limited. So again, I felt almost shut down, a little demeaned about the curriculum not addressing those important aspects of health. So it's experiences like that back to the hospital setting. As a young student nurse who was working a night shift, we had a First Nation client brought in, and he had fallen into a fire, and he had suffered some serious burns to his hands, his arms, and his chest. And he wasn't my patient that night. He was another nurse's patient. And she had come in after she did her med cart run, and she was talking to another colleague, and she had mentioned that, they're so shy, they don't say anything, so he didn't get anything. He must not be having that much pain. And I thought, good Lord, I burned my finger on a frying pan, and that hurts. It's just a little bubble. I couldn't imagine what he was going through. So I took it upon myself to go into his room, sit down, and after a 10-minute conversation, a little bit of humor, that must have been some res party, because, been there myself, done that. But when you see a First Nation person, Aboriginal person, their eyes light up. There's a little spark when they see another Aboriginal healthcare provider. And I really believe that we really need to start looking at our human resources, recruiting and retention issues. As Dr. Adams said, there are probably 1,000 registered nurses, Aboriginal nurses in Canada, and probably a little over 100 MDs in Canada. There's not very many, and we need a lot more, because we truly are best equipped to look after those of the same culture and the same experiences. But the double-edged sword of that is that can't be our sole responsibility as Aboriginal healthcare providers and professionals. We do need to have the partnership and the collaboration of these health authorities and the healthcare system that we work within. And continuing the education, I thought about population health. And I heard today a story about misdiagnosis and the terrible outcomes that can happen. It's so important to know your population and to know what's going on in that area. Just a little story, working in TB control, I thought, TB is such an old disease. It's really, it's not there anymore. Well, lo and behold, we've lost 3 Aboriginal people already this year to this terrible infectious disease in a country that is not supposed to have people dying of infectious curable diseases, but it happens. And so a physician in Emerge, again, close by a community that was having a rather large outbreak at the time, the person was admitted, and there was little inquiry around the community aspect, where this person came from, and this person was discharged with pneumonia. She was readmitted 3 weeks later, discharged again with pneumonia, and she did end up succumbing to tuberculosis. So it's still out there, and healthcare providers still need to be on top of areas where you are providing healthcare services. So with that, I'm just going to leave you my thoughts on cultural safety in regards to research. This is one step in regards to that process of achieving cultural safety, And I'm so very glad to see a lot of healthcare providers here today. And with this research that's coming in the new year, we hope that events like this will be shared and more community input involved in regards to cultural safety within health authorities. Thank you.
Thank you, Shawna.